surgeries within the last 3 months, or the people are already prone for retinal detachment. And you will also ask questions. Now this is a DME, so patients who definitely have had therapies before, so do I include them or do I exclude them? So this study, they have included 25% of the patients who had already had a treatment, others were treatment naive. So then what you will understand, this is the inclusion, the exclusion criteria. So then you will try to understand the molecule. As we saw already, this is how a vessel is maintained, the vascular stability. Especially important is the gap junctions, and around it is the pericytes, over it is the astrocytes. Now this is maintained by Ang2 inhibition. Ang1 acting on T2 receptors will maintain this gap junctions. So this has to always be in the active state. So this is in a DME or an NAMD. What happens? We saw the Ang1 is replaced by Ang2. So the tyrosine kinase is inhibited. The gap junctions will break off. The plasma will leak. Once the plasma leaks in any site, there will be inflammation. That is, the leukocytes will get attracted. The pericytes will fall off apoptosis, and Ang2 will act in synergism with VEGF. What it will do? It will increase the number of VEGF receptors, and it will increase the sensitivity of the endothelial cells to VEGF. And VEGF, we all know, it will immediately cause sprouting. Now, will the sprouting of the vessels be a regular vessel? No, it will not be. It will be immature, and hence a further leakage, this inflammation will continue. So, next question you will ask me is, you will ask me now what grouping should I put in? So, based upon if it is going to be a new molecule, how am I going to decide the dosage? So, you will do preclinical testing. From the animal dose, there is a formula to calculate the human dose. Or, I want to test a new molecule, I want to test the dosage. So, that any kind of reference if you have, even if you are able to quote one reference that is a PubMed, then you can put the dosing. So, here what they have done, the dosing was faricimab 6 mg every 8 weekly. And another one is faricimab, that is the treat and extend regimen, and aflibercept 2 mg every 8 weekly. So, the first is the loading dose that you will put. In the first group, for around 20 weeks, it was every 4th weekly. The second group, until 12 weeks, it was every 4th weekly. And aflibercept every 4th weekly until 16 weeks. Now, the treat and extend regimen is a personalized treatment interval. That is based upon the CST and BCVA. Once you see that the letter gain is increased, it is good, like 11 or 12. Then you will extend the interval from 8 to 12 weekly and 16 weekly. And if the CST is also reduced, the trying is there, that is less than 325, then again you will start increasing the frequency of the dosage. So this is mainly the PTI. How do we go about it algorithm? And then you will look into, has it achieved its endpoint? Yes. So we saw that the BCVA, the gain in letters of around plus 11.2, and the difference in that is around plus 0.7, faricimab around 8 weekly, and a personalized treatment interval. So we have to understand what is the main goal of this one. We just wanted to see whether the 16 weekly and the 12 weekly had obtained its level. So around by the end of week 52, 72% were able to shift into the 12th weekly and the 16 weekly regimen. And next is the CST. We had to see whether how was the CST and was it consistent, was it persistent. If you see, the levels are very good comparable, and the difference between faricimab and aflibercept was around minus 30 in the 8 weekly arm and PTI minus 22. Okay, what is the most important thing that FDA will look upon for any molecule? Is it the efficacy? It is the tolerability? Is it the safety? First thing is safety. First, the FDA will ask, is the molecule safe? So looking into the adverse events, we see how many is the adverse events, and we look in, it is an intravitreal injection. Obviously, we look into the intraocular inflammation, the uveitis, iritis, iridocyclitis. Most importantly is the endophthalmitis. Yes, there may be events because it is an intravitreal, it is expected and anticipated. But what has been the response after stopping the molecule? So in these two cases that we have seen, the molecule was stopped and then the patients had responded to the treatment, they have obtained their visual acuity to normal. And then how is the consistency and the durability of the molecule? Because it is not a one-time story. It's not like I'm going to give the drug, it is going to be a cure. It has to be a lifelong, or we will never know. So based upon the study, for 2 years, this has been consistent across all the groups. The only important thing is the number of injections. is reduced in the faricimab PTI, which is 11 injections, whereas 8 weekly, because it is 8 weekly, it is 15 injections, and aflibercept 14 injections. And you see a reduction in the CST. Early drying was also achieved. So this is the average for entire 2-yearly period, more than 100 weeks. And this is how many patients were able to put in the 12th weekly or the 16th weekly, which is around 72%. And by the end of 2 years, that is 96 weeks, both were around 78%. The important thing is the number of injections from 60 weeks to 96 weeks. PTI regimen, if you follow, it is hardly 3 injections, only 3 injections. Whereas Q8 weekly is 5 injections, aflibercept is 5 injections. So only by 3 injections, people were able to maintain in the 12 weekly and the 16 weekly arm. The intention to treat, again, that is very important. Any kind of statistics and studies, whoever we randomize, we take them as they are treated. Now there may be loss to follow-up, the patients would have missed the doses, we do not take that into account. Why is that important? Any real world study, it will just replicate the real world evidence. So again, here in ITT population, we see that the absence of DME, that is the drying, was seen earlier with faricimab. And this is the post hoc analysis. This is again done with Cochrane-Mentel-Hensel. Now what is Cochrane-Mentel-Hensel? See, now we are taking 2 molecules and the frequency of the injection is different. So how will I look into the adverse events? How will I look into the events? So this method will help me assess that irrespective of the timing of the dosage, and it will show me whether the drug is really good and based upon a significance of a p-value less than 0.05. But here we saw that the p-value was even less than 0.0001. So faricimab was well tolerated through the study end. We see that the events are similar to aflibercept. Now again, another thing is the exposure adjusted incidence rate, events per 100 patient years. Why is that important? Now I'm going to give today an intravitreal injection. I'm going to expect a response. But if I'm going to give them after 3 years, within that 3 years period, they will not have any kind of an adverse event. But then how do I compare 2 groups where the frequency of injection are different? Will not come under any kind of bias. To avoid it, we use this exposure adjusted incidence rate. So for any difference in the frequency of injection, we have to use in statistics this exposure adjusted incidence rate. So it will adjust and it will try to stratify the number of injections.
Good evening, Rajiv. Good evening, Padma.
So I think the event has started. So I'm just trying to conclude it. The events were similar. So with that, we come to the end of the presentation. We see that faricimab, which is a dual block inhibitor, angiopoietin 2 and VEGF-A, has shown significant effects with DME and
a lot more
NAMD.
thing to learn about
Yeah,
atrophy. Always we paid more concentration on active lesions.
Yeah.
This was a good experience.
Dr. Sadda. Great, you could join.
Hi, Rajiv. Hopefully
Great.
I'm audible. I'm on my
Yeah,
I'm on
you
my
are
phone.
audible. You are audible.
Inshallah. So.
Glad you could join.
How are you?
Hi, good evening to all of you in India, and good evening, Dr. Vas. Nice of you to join today. I'm sure you're having good time in China. We do have some questions for you when you weren't there yesterday, so we'll take it up during the course of the talks. And so today we'll have a little change in the schedule.
No, Chetan, can you take it because he has to leave because his net will be very small. If we can finish the question first and then start the day.
Well, I don't have a set of questions.
I remember yesterday there were a couple of questions.
Okay.
Last people wanted to know that infrared reflectance. What is your thought about GA and infrared reflectance images?
Yeah, so great question. One of the advantages of infrared reflectance is that it comes for free every time we get the OCT. And one advantage is that, when you do the OCT, if you don't do a dense enough volume scan, some of us, we don't do a dense volume, you can't do an on-phos rendering, in which case then you can't do measurements, but you can do it from the IR image. GA appears as a hyper-reflective region on the IR image. The only challenge with doing GA measurements relying on only the IR image is that you can have artifacts on the IR image, from but as the tracker was asking, it's very right on target. The point is that many outer retinal layers are involved. So you can measure the atrophy defect at the level of the photoreceptors, or the RPE, or the consequent hypertransmission, any of those levels. And so in terms of a volume, you could look for just like for macular edema, the DRCR network proposed using excess retinal thickening rather than just an absolute retinal thickness. You could consider using excess retinal thinning, which could generate a volume. So certainly very reasonable, certainly could be done. Whether that adds additional value for monitoring these patients obviously needs to be studied. But it's a great question, and certainly something that's feasible.
Thank you. Thank you very much for joining. Any other questions, please feel free to ask now. Okay.
And again, I apologize that I wasn't able to be. I was in flight when my video I think was playing, so I apologize that I couldn't join then. And unfortunately,
great talk, but the great talk.
The Google Meets is blocked by the Wi-Fi here in China. So that's why. Luckily, I was able to get through my phone connection and through a VPN to actually get through with you guys. So I'm glad to see it. So congratulations on a fantastic meeting. The program is outstanding.
Thank you. Thank you.
Sorry, I couldn't participate more.
Chetan, you can start the day.
So we have a small change in the schedule. So we have the first talk by Dr. Jenny Chung, as mentioned in the program. The next talk will be by Dr. Jay. I would request Dr. Padmavali to be in the next session after that, because Dr. Jay is already ready in his surgeon's dress. He's got a emergency macular and RD to take care of. So he would like to do the presentation a little earlier and get on with his OT. So I'll call upon our first moderator of the first session, Dr. Subneshwari. As you all know, she is a senior consultant in Shankar Nethralaya. And Dr. Subneshwari, she'll take over from here. Thank you.
Thank you, Dr. Chetan, for the very nice welcome address. And I'm happy here to invite our first speaker of the day. And she is going to be Dr. Jemmy Chan, who is the head and senior consultant of medical retina at Singapore National Eye Institute. So first, without undue delay, we will start with a presentation by Dr. Jemmy Chan.
Thank you very much for inviting me to participate in this program and to speak on atrophy in pathologic myopia. These are my disclosures. Atrophy features strongly in the development of myopic maculopathy. You're all familiar with the International PM classification of myopic maculopathy. We define pathologic myopia by the presence of posterior staphyloma, as well as the presence of myopic maculopathy from category 2 onwards. So here you can see category 2 is characterized by the presence of diffuse chorioretinal atrophy. You can see the color change on the fundus photography, in this case particularly co-localizing to the deep staphyloma. In the corresponding OCT, we realize that in this area, and possibly related or explaining the fundus experience, we note that there is extreme thinning of the choroid and choriocapillaris in this area. Moving to more severe types of atrophy in pathologic myopia in category 3, now we see patchy chorioretinal atrophy. These are usually characterized as well-defined grayish-yellow lesions, which are best appreciated stereoscopically. Their sizes vary between 1 to several choroidal lobules, and that relates to how they form and what's the underlying reason. We can observe large choroidal vessels and sometimes pigment clumping within these areas of patchy chorioretinal atrophy. In the corresponding OCT, as highlighted on the right here, you can see that there is hypertransmission in the areas of loss of outer retina, and in addition, there is loss of RPE and choroid. Basically, we can see the bare sclera through this area. In the corresponding FA and ICGA, again, we see hypofluorescence, which highlights that there is absence of RP and choroid in these areas. How do patchy chorioretinal atrophy form? It's been identified through longitudinal studies from Kyoko's group that there can be 3 main sources of patchy chorioretinal atrophy. The first is due to expansion of lacquer crack in the left hindmost example. The second source in the middle is within an area of diffuse chorioretinal atrophy. There may be patches of deeper patchy chorioretinal atrophy formation. And finally, on the right-hand side example, they can also form at the edge of the ridge of posterior statholoma. Here is a case that we followed up for about 8 years. On the left-hand side, you can see the well-formed patchy chorioretinal atrophy, luckily sparing the central fovea. On the right-hand side is how this eye started off 8 years ago. You can see areas of lacquer crack, and over the years, there is a bit of expansion around this area furthermore, and eventually coming to the final appearance that we observed in 2018. And we know that these patches will continue to expand and join up and causing larger and larger and coalescing scotoma patient's vision. Then let's move on to category 4, which is the most devastating in terms of visual impairment, this macular atrophy. So these are characterized as well-defined round chorioretinal atrophy lesions with grayish-white or whitish color. These are generally centered on the central fovea and particularly related to a regressed CNV. This has a round shape usually, as observed in these examples. In the corresponding OCT, again, we see the absence of outer retinal, choroid, and RPE, and in the center of that lesion, you may see a mound of subretinal hyperreflective material corresponding to the atrophic or scarred up CNV previously. So this is a case that progressed from an active CNV without much atrophy, and over 5 years, you can see the CNV has regressed, but what's remaining and what's most visually debilitating is a huge expansion of the surrounding area of macular atrophy. Here is another case. Again, on the left is the final picture. We see the patchy the macular atrophy. In the middle is a little gray area, which actually we have to refer back to realize that was once the CNV. On the right is how this lesion started off with. There was already an area of patchy chorioretinal atrophy. There is a clear active myopic CNV with hemorrhage. And as we treat that, the CNV becomes scarred up and inactive. There was some expansion of the surrounding atrophy. And with time, the CNV itself becomes more and more atrophic, but the surrounding areas of atrophy have joined up into a confluent round. In terms of CNV, we are all quite familiar with the therapy and the efficacy of intravitreal anti-VEGF agents. We recognize that we need to treat quickly during the active phase to regress the CNV. But while that is a kind of early success, it is important to realize that there is a late stage of the CNV in which atrophy can form around the regressed CNV. Unfortunately, anti-VEGF therapy doesn't actually help with changing the outcome of the atrophy. On the right-hand side, you can see a number of early studies which have described the late onset of chorioretinal atrophy development or macular atrophy development in eyes that were previously treated for myopic CNV. So what is interesting is that in some countries before anti-VEGF, PDT was used prior, and at least we found that with anti-VEGF, the incidence of macular atrophy still exists, but has become lower than compared with PDT days. So I've already mentioned earlier on, there is some discussion about choriocapillaris, choroidal lobules, and related to what is the proposed pathogenesis of atrophy in pathologic myopia, because increasingly we've come to realize that perhaps there are different pathogenic mechanisms compared to, for example, geographic atrophy. But still, number one on the top of the list is the ischemic component due to choriocapillaris trauma, such as early on we've talked about how PDT has been associated with a high incidence of atrophy development after control of myopic CNV. So why do we think ischemia is important? First of all, looking at the development of myopia macular degeneration, we know that the choroid becomes increasingly thin as an eye becomes more and more myopic, as you can see in these three eyes. As we move towards the bottom, there is increasing posterior bowing of the eye wall, indicating axial elongation, and you can see the corresponding choroid becomes increasingly thin. And in fact, in patients with myopic maculopathy or macular degeneration, we have evaluated the choriocapillaris using OCT angiography. And indeed, we found that choriocapillaris flow impairment was observed in many eyes, and even in those with mild fundus change. This can be a very early onset mechanism, and over the years, at least helps or aggravates the development of the macular atrophy. How does the what is the impact of intravitreal anti-VEGF, as we mentioned earlier on? So really, with anti-VEGF therapy, we've got stabilization of the visual acuity through controlling of the exudative activity, but multiple groups have continued to show that over the subsequent years, it may take several years, as you can see here is a 5-year study showing that while vision tends to stabilize, there is increasing expansion of the chorioretinal atrophy around regressed CNV. So luckily, we know that myopic CNVs don't need a lot of anti-VEGF therapy, so the risk of potential anti-VEGF therapy associated with the development of atrophy hopefully can be minimized. Here is another paper comparing the different modalities of therapy for myopic CNV. And as mentioned earlier on, it is rather reassuring to know that with intravitreal anti-VEGF therapy, despite continuing also to see some development of atrophy, the incidence is much lower than in the old days when we used PDT. So these kind of therapeutic observations, they do support the hypothesis that to a certain extent, traumatizing the choriocapillaris, in this case, particularly with PDT, does aggravate the situation when it comes to development of macular atrophy. However, there are additional theories in terms of the development of atrophy in the setting of pathological myopia, which is very different from geographic atrophy. In particular, we know that myopia is a very mechanical condition. There is axial elongation. The tissues are literally being stretched, and Brooks membrane splits when it comes to lacquer crack. So this very important finding from Kyoko Onomatsue and co-authors described the identification of Brooks membrane holes around the area of myopic CNV, and as the eye continues to expand and as the CNV regress, the expansion of this Brooks membrane hole may be an additional mechanism that contributes to the progressive enlargement of the atrophy around eyes with myopic CNV. So this is another paper from our group, which again illustrates, you can see the progressive changes in the OCT. You can see the opening up of that gap between that CNV and the adjacent Brooks membrane, which appears to also support the theory mentioned earlier on. A third hypothesis is that in addition to number 1, ischemia, number 2, mechanical breaks, is an inflammatory component, and many groups have tried to look at ocular cytokine levels and various cytokines, particularly those related to inflammation, as well as those related to extracellular matrix, such as the MMP class, and even autoantibodies have been found and associated with the development of myopic macular degeneration of higher severity. Nonetheless, I have to stress that these tend to be smaller scale, small sample size association studies, but nonetheless, they raise a hypothesis which I think it agrees with our clinical observations and requires further study. So with that, I'd like to conclude that atrophy is in fact a very important cause of visual loss in pathologic myopia. Currently, it is not being discussed very much because the development tends to be insidious and over a long period of time. And in addition, to aggravate the situation is that we don't have specific therapy for this. And talking about therapy, it is important to be able to understand the underlying etiology before we can develop the appropriate therapy. And I've highlighted at least 3 important mechanisms, ischemia being one, but also mechanical damage as well as inflammation have been raised as well. So I look forward to new data which will help us further understand this area and hopefully to develop effective therapy. Thank you very much.
So thank you, Dr. Javi. That was a wonderful list of details which you have provided to us, and in rather a new insight into the idea of what is atrophy in myopic macula. So we will come over to you for the discussion once we complete the next speaker's talk. So kindly stay with us for the discussion. So now I will invite Dr. Jay Chablani, and yeah, you want to play your video, Dr. Jay? You are muted.
Hey, Sugneswari,
Hi.
do you have my video there, or do you want me to play from here?
We have your video here.
You can play that video. That would be great.
Yeah. So before that, let me introduce you first.
That's important.
Yeah, we know each other for many years, but now beyond Jay as a friend, now I have to invite him to talk to us today on macular atrophy in diabetic retinopathy. He's a vitreoretinal consultant at the University of Pittsburgh Eye Center. So now over to Jay for you to give your interesting talk on atrophy.
Hello, everybody. I'll be talking about atrophy in diabetic retinopathy. These are my financial disclosures, none are relevant to this presentation. At this point, I would like to acknowledge my colleague Sumit Singh from Patna, who helped me with this presentation and shared few slides. We all have been talking about atrophy in retina, and whenever we speak about atrophy, the first thought comes in mind is the geographic atrophy in AMD, which is defined as loss of photoreceptors, RPE, and choriocapillaries. However, atrophy in diabetic retinopathy is not uncommon, but there is no uniform classification. The atrophy in diabetic retinopathy typically involves inner retinal layers, may not always involve photoreceptors, RPE, and choroid. So today I will be exploring some of the areas of atrophy in diabetic retinopathy. Before we get on to the atrophic changes in diabetic retinopathy, let's look at this picture, which clearly shows that diabetic retinopathy primarily involves the inner retina, where you can see these changes including microaneurysms, exudates, and these microvascular changes are pretty much related to the inner retina. And these changes rarely lead to the damage to the outer retinal structures. This is a postulated mechanism by which the retinal photoreceptors contribute to the development of diabetic retinopathy. I'm sure many of us have seen these figures earlier, but just to reiterate, the diabetes can lead to formation of reactive oxygen species, which leads to pro-inflammatory molecules, and which leads to capillary degeneration and changes of non-proliferative diabetic retinopathy, leading to proliferative diabetic retinopathy as it progresses. Let's look at various levels of atrophic changes in diabetic retinopathy, including inner retina, outer retina, and choroidal changes. Way back in 2015, we showed early neurodegeneration in type 2 diabetes in eyes which did not have any diabetic retinopathy or minimal diabetic retinopathy. In this paper, we showed early thinning of inner retina can happen even before visible vascular signs of diabetic retinopathy. I believe that this paper proved that diabetic retinopathy is primarily a neurodegenerative changes before the vascular changes appear clinically. As we can see on these figures from GCL thickness maps from serous OCT, which clearly shows that there is thinning of the ganglion cell IPL complex even in a patient with very early diabetic retinopathy changes. Recently, we have learned about a new term called drill, which is clinically defined as a region on OCT-B scan where the boundaries of GCL and IPL complex, INL and OPL could not be separated, identified. Here you can see on an insert that how these inner retinal layers are indistinguishable on the OCT scans. And we believe that drill is primarily due to bipolar axons when they snap, when their elasticity limits have been exceeded due to edema. It represents the loss of bipolar, hemicrine, or horizontal cells within the inner retinal layers. We have been using this sign not only diabetic retinopathy but other microvascular diseases, including branch retinal vein occlusion and central retinal vein occlusion. What about outer retina? We understand that ELM disruption usually first to occur, and this ELM disruption allows these blood components to reach and potentially damage the photoreceptor layer, which leads to disruption of EZ, subsequently to the disruption of ELM. As we can see in this figure, where there is an inner as well as outer retinal thinning in a patient with diabetic macular ischemia, as shown on OCT angio. This is one more example where we can clearly see the outer as well as inner retinal changes, and here you can appreciate the RP atrophic changes as well as a sign we can see here as hypertransmission defects. Let's talk more about RP and choroidal changes. RP dysfunction and leakage from choriocapillaries are associated with impaired fluid clearance and edema in the outer retina, which happens usually in late stages of diabetic maculopathy. There is controversial reports on choroidal thinning, which correlates with HbA1c levels as well. We understand that there could be a choroidal atrophy. Let's look into this in more detail. What about diabetic choroidopathy? Severity of choriocapillaries dropout related to the thickness of Bruch's membrane deposits in diabetic choroid. Diabetic choroidopathy could have a subsequent profound impact on RPE and outer retinal layers, which are oxygenated by choriocapillaries. This work from late Professor Lutti showed there is a significant damage to the choroidal structures, and as you can see in the last figure, there is a complete loss of choriocapillaries. Inspired by that work on histology, we looked into our Indian cohort in 2016, and we published this paper in IJO where we showed that eyes with diabetic retinopathy, there could be a choroidal thinning which can contribute to the diabetic retinopathy pathogenesis. Then we also looked into the wide field OCT images, as we can see here, up to the mid-equatorial region. The spectral domain OCT images were obtained. And when we looked at the choroidal analysis on diabetic retinopathy in wide field OCT, here we can see that these choroidal changes were also present almost up to the mid-equator, and there was a significant choroidal thinning as we moved forward, and there was changes in the choroidal vascularity index as well. So what are the overall predictors for retinal atrophy in diabetic retinopathy? We understand that patients undergoing laser, including great focal or PRP, can have retinal atrophic changes due to inner retinal changes. And we see these changes even after vitrectomy as well as ischemic maculopathy. And there is some evidence coming along that after intravitreal anti-VEGF therapy as well as steroids, there could be retinal atrophy in these eyes with diabetic retinopathy. With this, I would like to summarize that atrophy in diabetic retinopathy include inner retina, and these inner retinal atrophic changes, which represent as reduction in ganglion cell layers as well as RNFL layer, could be earliest signs of diabetic retinopathy well before the vascular signs are seen clinically. We have recently learned about drill, which is now becoming part of our clinical practice, where we have been looking at this sign in changes due to diabetic retinopathy as well as other microvascular diseases. What about outer retina? There is certainly a damage to the outer retinal changes, including ELM as well as EZ, and it can lead to RP atrophic changes as well. And we also showed the evidence that there are changes in the choroid, ranging from histological changes of loss of complete choriocapillaries to choroidal thinning on OCT in the clinical settings. However, there is lots to learn on the choroid in diabetic retinopathy. With this, I would like to thank everybody for their attention. Thank you very much for this kind invitation.
So I must congratulate both the speakers for the extremely very nice, well summarized talks. And I think first we will now speak to Dr. Jay about his talk, because he has to go for a macular and retinal detachment. As real surgeons, we all understand that's a priority. So Jay, you escape with that. So now I will call upon all my who are going to be the panelists. It will be Dr. Avinash Patanke from LV Prasad, and Dr. Anand Rajendran, and Dr. Moona Bende. Ma'am, are you there?
Sorry, Jamie.
Yeah. And Dr. Kim.
Okay.
Dr. Kim, sir, are you there?
Yes, I'm here. I'm on the show.
Yeah. So, good evening to all of you here. So now we will start the discussion on both these topics, and first we will start with the diabetic retinopathy. So I will ask our most senior person here, Dr. Kim, because he has been dealing with diabetic retinopathy for many years. Sir, in your purview, what do you think should be the most important biomarker which could be an probable sign to tell us this patient will end up having a macular atrophy in diabetic retinopathy?
I think one of the most important thing is the thinning that happens in all these patients, especially the chronic ER changes patients. So that will be one of the signs to show that this patient is unlikely to improve over a period of time. So that is the only thing I would think of. Of course, when as Jay pointed out about the drill, I think that's another important factor in these patients where the vision is unlikely to improve much further.
Thank you, sir, for the very nice comment. And now I shall request Dr. Anand Rajendran. Do you think that excess accumulation of hard exudates could probably be a marker to tell us, yes, this patient will end up having atrophic areas in the macular area?
Yes, certainly. I mean, we do know it's kind of intuitive that, the presence of extraneous material like lipids or even hemorrhage, excessive amount of that is going to have not just from the biochemical aspect, but also from the weight, simply the volume and the weight aspects. There is going to be a deleterious effect of these hard exudate clumps bearing down on those photoreceptors from above. So that's definitely there. In fact, I had that also penned down, as a thought that any case vis-a-vis two individuals with the same macular thickness, one having very just pure, serous fluid, intraretinal or subretinal, and then vis-a-vis another one having the same volume, but laden with, these hard exudates. So definitely the ones with hard exudates would have a deleterious effect. So that definitely that I think is something that needs to be seen, which is why when we talk about control of diabetic macular edema alongside diabetes, we also look at the entire biochemical profile and advise patients look at the lipid profiles and correct that at the earliest. And we know from Dr. Amod Gupta's paper decades ago that patients did better, and that there was a crucial role of statins and control of lipid control, and that was also seen in the West DR study also. Yeah, for sure.
Yeah, thanks.
So I have a question for Jay once you finish with that.
No, I think you can go ahead with your question. No problems.
Yeah, I just, Jay, so you talked about diabetic choroidopathy, and that's something we all, very excited to hear about. I just want to know if there's any, early neurodegenerative signs in the inner retina or even outer retina, which can tell us that these particular patients will go in for diabetic choroidopathy. What I'm trying to say is there any correlation between, the retinal changes that are happening and the changes that are happening in the choroid? Because we are beginning to understand from work, especially like doctors and people like Dr. Vasa's studies with the AMD, that choriocapillaris is now a very intensively studied area, and it has both vascular implications as well as neuronal. So just do the early signs, neurodegenerative signs of, inner retina specifically, will they herald the cascading effect on the choroid, specifically the choriocapillaris?
Thanks, sir. As usual, very good question and very thoughtful. I would say that in my experience, we have done a lot of work in the diabetic choroidopathy, starting with spectral domain OCT, as well as we did publish some of the choriocapillaries loss work in diabetic macular edema. I can say that, the inner retinal changes may not really relate with the choroidal changes, because we believe that the choroidal changes are still happening along with the outer retinal damage instead of inner retinal damage. And now, after the drill identification or the work from UK, we learned that the drill could actually be the first sign in diabetic ischemic maculopathy and and these microvascular diseases. So unlikely that it can correlate with the available choriocapillaries damage, because still I don't think that the choriocapillaries imaging is up to the mark where we can confidently say that this is due to choriocapillaries flow voids. Because in diabetic patients, the work which we have done, we obviously understand that there were some artifacts because of the outer retinal damage or RP changes due to the long-standing cyst. So it is very unlikely that at this stage we are able to correlate directly with inner retinal changes and choriocapillaries changes.
So there is some questions, I think, Jay, for you from Dr. LG. He has asked, what does drill signify structurally? Is it gliosis that has replaced these layers?
Sir, the drill which they have described, and obviously we don't have any histological confirmation of these findings, but what we believe and the papers which they have published, we believe that this is primarily due to ischemic changes which are going on in the inner retina, particularly affecting the bipolar and horizontal cells. But I can definitely agree with you that there could definitely be a gliotic reaction to this ischemia, which we expect whenever there is damage to the horizontal or amacrine cells. There could be a gliotic changes which are going on, and that's why probably there is significant disintegration or undifferentiation of the inner layers. So probably there is some gliosis going on due to the ischemic changes, which we also see in eyes which develop cotton wool spots, or eventually when the ischemic changes regress in RNFL.
So now to Dr. Avinash, do you feel that there is going to be a role for an ICG? Because we all know that we've been used to, or rather tuned to, doing fundus fluorescein angiogram to see diabetic retinopathy. Well, we are doing non-invasive OCTA also, Opta. But do you think there would be a role for ICG?
No, I'll keep it very short. The answer is no. Right. So as of now, we are still trying to understand more about how the choriocapillary functions in terms of its functionality and in terms of the imaging modalities as well. So in its current form, I don't think so, since it does not even herald the progression of inner retinal changes. Even if you find certain changes, it's the extensivity of the disease which happens in the inner retina overwhelms what happens in the choriocapillaries, even if it's in the early stages. So to me, I would not use it.
So as we all understand, Indians mostly have most of us have a pachychoroid spectrum. And when we say that we also have this diabetic retinopathy, which is so much predominant, so there is quite a controversy between things what is happening, because we have florid diabetic retinopathy also being here, that is again related to the poor control. But then with both these things happening, both with pachy spectrum and with the choroidal thinning, so what do we expect? How would it be in terms of progression?
You're asking me?
Yes.
Or you're...
No,
Okay,
I'm asking you.
No, be honest, I'm not a pro ICG person. I think you have to ask Jay for that. So for me, ICG is not a very significant tool in my diagnostic armamentarium. So I don't use ICG that frequently for me to comment on it legitimately.
So now Jay
I think Jamie is the expert with pachychoroid and ICG. She has published quite a bit.
So Jamie, you can take up this.
I agree with Dr. Avinash. I don't think ICG in particular is that useful for looking at choroid. As mentioned for OCTA, because it's really the choriocapillaris which gives us a bit more detail rather than the large choroidal vessel. So OCTA in particular is useful. What that discussion earlier on made me think was that it's been shown that all the plexuses are affected in inner retina, superficial retina deep, and choriocapillaris are all affected in diabetes. That it would appear that we still don't have an understanding of the longitudinal progression, which one the loss is faster, and in fact, what is the pattern of progression in each of the plexus? That would be something very interesting to understand.
So now to Jamie for your talk, which has been a really very interesting talk and on the myopic atrophy. So I would like to ask you one question, like do you do functional assessment in these patients also? Like for instance, the role of microperimetry in assessing the atrophy?
Well, not really in terms of clinical practice, no. Yeah, that's the short answer. Yeah.
So what are your, how should we prevent this atrophy from occurring? Because there is a question from Dr. Jayaprakash as repeated anti-VEGF injections for the CNVM. Do they contribute to the enlargement of myopic macular atrophy? Because in your talk, you had elaborated on how the different modalities can cause, but do you think repeated injections could be a causative factor also?
Yeah, I think that's a very important and very good question. And certainly in terms of, at least from a theoretical level, that is something that we do worry about. The good thing is, well, the bad thing first. The bad thing is that despite its effectiveness in controlling myopic CNV, we do see delayed atrophy continuing to develop. So it doesn't stop it from happening. But the good thing is it definitely happens much less than in the old days with PDT. And the other good thing is we know that generally myopic CNVs don't need a lot of injections. So at least that is quite reassuring. We don't do treat and extend in myopic CNV, and probably it's not a good idea to do so in these eyes with a relatively kind of weak choriocapillaris. But nonetheless, if you think on average, these eyes are only needing about 2 to 3 anti-VEGF injection, then the myopic CNV settles and becomes inactive. And then when you continue to follow them up, the choriocapillaris still slowly develop much later in terms of time scale than after we stop the anti-VEGF. So I think the most important factor driving that currently is still something else that is happening later on after the myopic CNV has settled down, after we've finished treating with anti-VEGF.
So now in your talk, you did highlight about the pathogenesis, wherein you spoke about the ischemic component, the mechanical component, and the inflammatory. So what I would also like to know is, as a part of the inflammation, did you have any opportunity to study the eyes in which where a lot of barrage is required for lattice degeneration and all those things. In those eyes, did you see a progression of the atrophy in any of your set of patients?
I think they're quite different because those eyes that we do laser on are in the periphery. So they are not directly so much linked to what happens in the posterior pole. In the posterior pole is those eyes that have posterior staphylomas in that area that are particularly prone to macular atrophy. So in that sense, I haven't been seeing that much connection. In terms of therapies, so we've talked about what may make things worse. I mean, currently there's really no clear answer to what can alleviate the situation. But in terms of if we think of along the lines of slowing down the expansion of the eyeball, we know that these pathologic myopia eyes, despite in adulthood, continue to elongate. So in theory, experimentally, there are some approaches suggesting maybe we give some sort of IOP lowering medication just to kind of deflate the globe a little bit, or so that it doesn't sit on so much stress. That is one theory. What is the role of atropine in these kind of eyes? Actually, there is really no data. And the kind of expansion in adults in terms of mechanism can be very different from that in children. So, but again, these are theoretical points that require further evaluation.
So I guess there is one question for you, Jamie, that is, which category of myopic chorioretinal atrophy has more chances of myopic CNVM formation?
Okay, we've looked at that in the mirror study. In fact, so it's quite interesting that you can have myopic CNV developing at any stage from category 2, 3, unlikely to be 4 because 4 tends to be a consequence of the myopic CNV. But the risk is higher with patchy atrophy, and we know that these myopic CNV can often grow at the edge of a patchy atrophy. But in terms of the population, we know that the distribution, in terms of distribution, is in a pyramid. So there are more patients with diffuse atrophy. So we can't say, oh, just because it's diffuse atrophy, there are going to be less myopic CNV. They still contribute, although per se the percentage point is lower, but there is a larger number of those patients.
We could not hear you, Sugneshwari. Did you say, was it muted?
Oh, yes, sir. No, Dr. Pramod Bende wanted to ask a question, I suppose. Sir, you can ask. PB, sir? Okay. So in that case, now I will pass on to the next moderator. So the next moderator of the session is going to be Dr. Girish Rao, who is the senior consultant and also the president of the Medical Research Foundation. So over to Dr. Girish Rao.
Good evening, friends. So happy to note that the chat box is being flooded with questions, and I hope that you'll continue that stream as we move on to the next session. We'll be having Dr. Padma Malini, who will be speaking. Dr. Padma is a uveitis and oculoimmunology specialist from Narayan Nethralaya, Bangalore, and she'll be talking to us on atrophic versus active lesions in uveitis. And this will be followed by a talk by Dr. Chetan. So over to you, Dr. Padma Malini.
All of you. At the outset, I would like to thank Dr. Rajiv Raman and Intesh Nethralaya team for inviting me here today to speak on active versus atrophic lesions in uveitis. In the next 15 minutes also, I would like to talk regarding the clinical assessment of inflammation, role of multimodal imaging in the diagnosis and management of uveitis with the case examples, and pattern recognition of uveitic entities with take-home points. The clinical assessment, posterior segment inflammation are estimated by measuring the amount of cells and vitreous hairs in the posterior segment of the eye. Next comes multimodal imaging. Here we have color fundus photography, multicolor imaging, red-free or infrared imaging, fundus autofluorescence, fundus fluorescent angiography to study the retinal circulation, indocyanine green angiography, ICG, to study the choroidal circulation. In vitro histopathology of the retina, we study by using optical coherence tomography, and retinal and choroidal vasculature are studied with the help of ARCTA. Wide field angiography plays an important role in the diagnosis and management of uveitic entities. We'll go by structure-wise. The optic disc can get involved secondary to inflammation presenting in the form of a disc edema versus secondary optic atrophy. Here is a patient where you see a disc edema, vascular sheathing secondary to sarcoidosis, has blurring of the disc margin, tortuosity of the vessels with sheathing, and hemorrhages can be present around the disc. Optic atrophy, we see in end stage or burnt out of uveitic entities. They have gray or dirty gray disc, overly delineated margins, obscuration of the lamina fibrosa with reduction in the number of small blood vessels with associated sheathing of the vessels. Capillaries are estimated with the account of capillary number index or Kestenbaum index. The normal is about 10 capillaries. Whenever it is less than 6, we call it as optic atrophy. We'll move on to the case examples. The retinitis, most of the times it occurs secondary to infectious. Toxoplasmosis is the commonest cause of infectious posterior uveitis. Classically, we present in the form of head-like and the fog appearance, characterized with the presence of active whitish edematous retinochoroidal lesion as seen in this photograph. OCT shows hyperreflective oval deposits at the vitreoretinal interface with increased hyperreflectivity in the inner and middle retinal layers with a choroidal bulge. Following treatment with antitoxo and systemic steroids, we could see the incomplete PVD with taut posterior hyaloid, distortion of the inner and middle retinal layers with resolution of the choroidal bulge. Here is another case of acquired toxoplasmic retinitis as fluffy white retinitis. OCT shows posterior vitreous cells, full thickness retinal involvement. Following treatment, we could see the healed chorioretinal scar, that is sharply demarcated atrophic scar with pigmented borders. OCT shows thinning and atrophy of the affected retinal tissues with thin membrane on the surface with subretinal fibrosis. Next, we'll move on to acute retinal necrosis. Here, it's classically described as Swiss cheese pattern with infiltrative pattern of keratic precipitates on confocal microscopy. This is secondary to varicella zoster virus infection, shows inner retinal hyperreflectivity, disorganizations and disruption of the retinal layers. Following treatment with antiviral and systemic steroids, we could see the resolution of the retinitis with thinned out retina. Next, we'll move on to post-fever retinitis. Here is a patient with retinitis in the posterior pole secondary to chikungunya infection. OCT shows hyperreflectivity with aftershadowing with intraretinal hyporeflective cystic spaces with subretinal fluid. This is normally seen in all forms of post-fever retinitis. FFA shows early hypofluorescence with late hyperfluorescence. Following treatment, we could see the complete resolution of the retinitis with improvement of visual acuity into 6.6. However, anatomically, we could see thinning of the nerve fiber layer of the retina. What are the functional impairment occurs following this thinning? There was a decreased contrast sensitivity and visual field defect present corresponding to the areas of the retinitis, and there was an abnormal macular integrity on microperimetry. Multifocal ERG shows diminution of response within 5 degrees of fixation. P1 amplitude subnormal in central 2 rings. This is another case of post-view retinitis where we described ring infiltrate in a case of rickettsial retinitis. Multicolor imaging can be used to study the structural involvement at different depth levels. In active, we see whitish lesions, mainly on the blue and green reflectance images, whereas dull green reflectance is seen in resolving or resolved retinitis cases. Wavelength have been used to study the different depth levels. Optical coherence tomography shows the alteration of the retinal vasculature in patients with post-view retinitis. Here, rarefaction of the deep capillary fluxes are more compared to the superficial capillary fluxes. FAEZ is enlarged and irregular. This can be imaged once the edema resolves. Next comes CMV retinitis, where we see the necrotizing retinitis in both eyes. OCT shows disorganized retinal layers with hyperreflectivity with full thickness involvement and thinned out retina. Following treatment, we could see the resolving retinitis. OCT shows thinned out retina in a healed retinitis cases. Here is a case of a post-COVID retinopathy showed rain cloud sign, turned out to be a candidiasis. Following treatment with antifungal therapy, we could see the resolution of the lesions with atrophy of the retinal layers. Next, we'll move on to choroiditis. Tuberculosis is the commonest cause of infectious choroiditis. Here you could see the yellowish white, indistinct margins underneath the retinal vessels. Autofluorescence shows hypo with surrounding hyperautofluorescence. FFA shows early hypo with late hypofluorescence with disc leakage. OCT shows full thickness choroidal granuloma with subretinal fluid. Following treatment, we could see the resolution of the granuloma with scar formation in the choroid, showing as hyperreflectivity at the level of the choroid with the distortion in the outer retinal layers. Next comes sarcoidosis. Here you could see the multiple choroidal granulomas. They are round. They can have partial thickness involvement. Predominantly, it involves the saddler layer. Following treatment, we could see the resolution of the granuloma. Serpiginous-like choroiditis is commonly seen in our part of the country, secondary to tuberculosis etiology. Autofluorescence shows hypoautofluorescence in the right eye. In the left eye, we can see hyperautofluorescence in addition to hypoautofluorescence suggestive of active lesions. FFA shows early block fluorescence with late hyperfluorescence with staining of the polyretinal scars. OCT shows distortion of the ELM, myoid ellipsoid zone, hyperreflectivity in the outer retinal layers with increased choroidal thickness. Following treatment, we could see the complete resolution of the choroiditis lesions in both eyes. But when we did the adaptive optics, we could see the cone cell count has significantly decreased to around 5,000 compared to the age-matched normal controls. And also we could see the areas of hyper hot colors corresponding to the areas of the chorioretinal scars in serpiginous-like choroiditis. In serpiginous choroiditis, it's immune-mediated, affects mainly the peripapillary region. Following treatment with steroids and immunosuppressive therapy, we can see the decreasing hyperautofluorescence in the patient. Type of autofluorescence: whenever hyperautofluorescence suggestive of active lesions, hypo suggestive of a healed choroiditis lesions. When we see hyper with hypo during the healing phase of choroiditis. In addition to the descriptions, we also have done the quantification of fundus autofluorescence in serpiginous-like choroiditis. The following paradoxical worsening, we stepped up the dose of systemic steroids and immunosuppression, following which we could see the resolution of the choroiditis. So it's depicted as complete hypoautofluorescence, and which has been measured in this patient. We also described choroidal vitiligo, that is hypopigmented choroidal lesions following herpes zoster. ICG shows hypofluorescent lesions. OCT shows cystoid macular edema with choroidal granulomas. Following treatment with antiviral and steroids, we could see the resolution of the granuloma in this patient. Next comes punctate inner choroidopathy. It's classically seen in a female unilateral myope. Whenever you see a fundus lesions like this, we suspect punctate inner choroidopathy. FFA and ICG shows hypofluorescence with staining of the vessels. FFA shows staining of the chorioretinal scars. ICG shows hypofluorescence, whereas hyperfluorescence corresponding to the areas of the CNVM with the lacy pattern on ICG. Following the OCT, we see there is disruption in the outer retinal layers with hyperreflectivity in the outer retina. This patient had associated choroidal neovascular membrane. Following treatment with anti-VEGF, we could see the resolution of the CNVM in this patient. Next comes pan-uveitis. Here is a case of a sympathetic ophthalmia where you could see the choroiditis lesions along the vessels, shows subretinal fluid, increased choroidal thickness with vessel layer detachment. Following treatment, we could see the presence of irregular hyperreflective area located at the outer retina. Next comes VKH disease. They can develop sunset glow fundus with Dallenfuchs nodules. ICG shows hypofluorescent lesions in both eyes. OCT shows hyperreflective area corresponding to the areas of choroidal granuloma suggestive of active inflammation. In another areas, it shows hyperreflective nodule in outer retina corresponding to the areas of Dallenfuchs nodules. Coming to the pattern recognition, whenever we see a patient with circumscribed chorioretinal scar, most likely secondary to toxoplasmosis, vasculitis with scar along the vessels commonly seen in tuberculosis. We see a trizonal pattern of autofluorescence. We suspect azure, that is acute zonal occult outer retinopathy. Peripapillary lesions suggestive of serpiginous choroiditis, mostly secondary to immune-mediated disease. We have a peripheral granuloma with the falciform like a fold in case of toxocariasis. Lesion like this suggestive of a pig. Whenever we see a scar, are they really inactive? It's important we need to study them as well. OCT revealed underlying CNVM in this patient, which shows hyperreflectivity with subretinal fluid. Following anti-VEGF therapy, we could see the resolution of the CNVM in this child. To conclude, active whitish edematous retinitis or choroiditis lesions are distinguished from cicatricial, pigmented, and atrophic lesions. Multimodal imaging helps us to differentiate the active from atrophic lesions in many posterior and panuveitic entities. Hyperautofluorescence suggestive of active lesions. Heel lesions or scars shows hypoautofluorescence. OCT shows thickening with hyperreflectivity of the layers of the retina. The retinochoroidal scar shows retinal atrophy, interruption of the outer retinal layers. In severe cases can lead to subretinal fibrosis. I would like to acknowledge the key members for the contribution. Thank you for your attention.
Thank you, Dr. Padmavani. That was a very exhaustive and nice illustration of various bouquet of conditions with both the active and the inactive stage of the disease. Please stay on for the discussion, which we will have at the end of the next talk by Dr. Chetan Rao, Senior Vitreoretinal Surgeon at Sri Bhagwan Mahavir Vitreoretinal Services at Shankar Netralaya, and he will be talking to us on neuroretinal atrophy following the resolution of macular edema in the retinal vein occlusions. So over to Dr. Chetan.
Good evening, everyone. I'll be speaking on neuroretinal atrophy following resolution of macular edema in retinal vein occlusion. I will be attempting to answer the question regarding what factors drive the development of retinal atrophy in vein occlusion. Assuming retinal atrophy is one of the causes of poor visual recovery following treatment or in the natural course of the disease after a vein occlusion event, when do we actually recognize it as a cause of vision impairment? We all know that the immediate aftermath of a vein occlusion we see macular edema causing vision impairment. However, we will see in the subsequent slides that atrophy is due to apoptosis, and apoptosis in the retinal neurons start immediately or simultaneously with the development of macular edema. Only late in the course of disease we see retinal thinning due to atrophy. Macular edema is seen in 15% of cases of branch retinal vein occlusion in 1 year, whereas it is seen in 100% of cases of central retinal vein occlusion at baseline. 1/3 of the macular edema cases in branch retinal vein occlusion or non-ischemic central retinal vein occlusion will resolve spontaneously, whereas 70% of macular edema cases in ischemic central retinal vein occlusion will spontaneously resolve by 15 months. And chronic macular edema leads to destruction of the macular architecture. Central retinal vein occlusion is of two types. In the non-ischemic central retinal vein occlusion, 17% of cases will have less than 6/60 vision over a long period of time, whereas in the ischemic variety, 85% of cases will have vision less than 6/60 and will also have a scotoma in 78% of cases. This indicates reduction in the retinal sensitivity and possibly due to retinal atrophy. Let us see the sequence of events that cause vision impairment after retinal vein occlusion. After the vein occlusion happens, there is a reduction in the blood flow. There is hypoxia ischemia in the retinal tissue, the severity of which depends upon the duration and the severity of the occlusion itself, which leads to endothelial damage. A cascade of biochemical events happen which leads to increased vascular permeability, leading to break in the blood inner retinal barrier, intracellular cystic edema, and macular edema. Biochemical changes include release of pro-inflammatory cytokines of the interleukin family, and the retinal neurons, glial cells, and endothelial cells induced vascular endothelial growth factor production. That leads to intracellular edema primarily in the ganglion cell, the plexiform layers, and the inner nuclear layer. So just like after a CNS stroke, there is a neuronal adaptation that helps in neuroprotection. Is there a similar response in the retina? Hypoxia ischemia causes simultaneous pathways of apoptosis that helps to clear dead neurons, and a pathway of neuroprotection response to promote cell survival. There is an immediate activation of the apoptosis-inducing protease called caspase. This pathway causes pycnosis of cells first, at which stage it can still be reversed before the cell death actually occurs. However, caspase via non-apoptotic action causes dysfunction of endothelial cells that potentiates the action of VEGF and worsens the edema and the vascular occlusion. Experimental evidence shows that a combination of caspase-9 inhibitor and anti-VEGF helps in reducing the retinal edema and eventual atrophy. Neuroprotection starts with upregulation of VEGF, and the response is inconsistent as it depends on the injured vessels and that remain perfused, and the levels decrease once endothelial cells are dead. But there are other cells like glial cells that continue to secrete VEGF. VEGF-A plays a neuroprotectant role by direct action on retinal ganglion cells. Ischemic precondition is an adaptation response of the neuronal cells for survival, and VEGF-A is the main factor driving this. It is important to know that anti-VEGF injections have been implicated in blunting this pathway, leading to subsequent loss of ganglion cells and retinal atrophy. In the light of dual role of VEGF in promoting macular edema and neuroprotection, the question arises whether the treatment with anti-VEGF is effective in preventing retinal atrophy. Wodkolski et al. Conducted a post-hoc analysis of crystal and brighter studies. In these studies, monthly injection of ranibizumab was given for 3 doses followed by PRN dosing up to 6 months. OCT images, fluorescent angiography, and visual acuity were analyzed at 6 months. Retinal thickness was measured in 3 compartments in 4 quadrants around the fovea. They reported retinal atrophy in approximately 11% of cases of their study population. There was maximum reduction in the inner proximal layer, outer nuclear layer zone that corresponds to the area supplied by the deep capillary plexus. Eyes with retinal atrophy had a baseline low visual acuity. However, there was weak predictive value for development of atrophy. They found that fluorescent angiography was not a reliable indicator of non-perfusion in the acute stages. This leads to the question if there is any way that we can predict retinal atrophy by studying OCT changes. Hasegawa et al. Used hyperreflective spaces in the retinal nerve fiber layer in severe macular edema to predict retinal atrophy. Argued that hyperreflective spaces suggest edema in the retinal nerve fiber layer, which is usually very compact, but develops these spaces due to loss of tissue from ischemia-induced apoptosis. As seen in this slide, the arrows show the hyperreflective spaces in the RNFL at the time of macular edema, and then there is inner retinal thinning on resolution of the macular edema. This is an example of the same in one of my cases, though the hyperreflective space is not that eloquent, but the same area is thinned after resolution of macular edema post anti-VEGF injection. Another group described an entity called prominent middle limiting membrane in acute central retinal vein occlusion of less than 1 month duration that can predict retinal atrophy. They described hyperreflective line at the upper limit of the outer plexiform layer that signifies capillary ischemia in the deep capillary plexus similar to paracentral acute middle maculopathy, which leads to inner nuclear layer thinning later on and signifies ischemic central retinal vein occlusion, and that can be used to predict reduced vision recovery. However, the limitation is that it is difficult to identify this particular biomarker in cases of severe macular edema or macular hemorrhage. With the advent of OCT angiography, it has become easier to confidently look at the superficial and deep capillary plexus, the retina, and use the various vascularity indexes to quantify the pathological changes that occur in RVO. Lee et al. Showed that superficial vascular complex vessel density correlates with the retinal thickness after resolution of macular edema. They concluded that if the baseline vessel density is less, then the final retinal thickness will be less, secondary to the retinal atrophy. Brachima et al. Showed a positive correlation of perfusion density at 1 month after anti-VEGF injection with retinal sensitivity after macular edema resolves by 1 year. In areas of severe reduction of perfusion density, the retinal sensitivity was less, which is an indirect marker of retinal atrophy. In addition to retinal ischemia as a cause of retinal atrophy, the morphological changes that occur in chronic or refractory edema lead to cystic macular degeneration and loss of photoreceptor and macular pigmentary changes. These changes could be attributed to development of serous macular detachment or submacular hemorrhage or massive fluid accumulation in the outer nuclear layer after occlusion. If treatment is not started early in branch retinal vein occlusion, the edema becomes refractory and has been attributed to development of microaneurysms that are manifestations of endothelial injury and remodeling. So what treatment strategy is ideal to reduce the inner retinal atrophy? We know that ischemia is the primary driver of atrophy, and worsening macular edema can cause further progression of the retinal ischemia. Therefore, a VEGF treatment should be started as early as possible. However, there is a caveat. To reduce the apoptotic damage, treatment can be delayed up to the point where the macular edema peaks. In BRVO, the macular edema peaks by around 6 to 8 weeks after occlusion, at which point of time anti-VEGF treatment is ideal. Novel therapeutic targets to control apoptosis should be developed, such as caspase-9 inhibitors. Lastly, reducing inflammation and macular edema using intraretinal dexamethasone monotherapy or in combination with anti-VEGF will help in reducing the outretinal atrophy. I thank you all for patient listening.
Thank you, Dr. Chetan, for a very exhaustive talk on the neuroretinal process of damage or the auto-regulation that happens in vein occlusions. Now, I'd like to invite our esteemed panelists. We'll have Dr. Jyotirmay Biswas, the head of the Department of UVR Services at Chikanetalia, Dr. Partho, who is the senior consultant in the UVR department, and Dr. Avinash. So I'll first concentrate on the UVR session. So Dr. Biswas, the first question would be, are there any different patterns of atrophy due to the various subtypes of uveitis, say choroiditis, retinitis, or vasculitis, that could give us a clue to the diagnosis?
Not really. Whenever there is atrophy occurs, there is a well demarcation of the line, which is bloody or ill-defined earlier, it becomes well-defined, and then pigmentation sets in, and this can be clinically seen, and optical autofluorescence can detect such kind of changes very well, and earlier we didn't have that. And then also, of course, fluorescent angiogram and OCT can help in that, seeing the changes. Some of the time of the choroiditis has got in our country develops a lot of retinal chorioretinal atrophy, as well as the pigment proliferation, and that leads to loss of a lot of visual loss and subretinal scar formation.
Is there any difference in the pattern of atrophy between what we say as a retinochoroiditis versus a chorioretinitis?
Not really is that clinical.
Dr. Avinash, would you like to give your comments on this?
Yeah, I would like to have a contrary thought. So pattern can still be made out, is a significant clue to make a diagnosis. Now let's consider why when you talk about atrophy in infectious conditions or in inflammatory conditions. Now we talk about two conditions, where is hyperpigmented chorioretinal atrophy, if the term is applicable, or non-pigmented chorioretinal atrophy. So let's divide into these two things. So now where it becomes relevant, now in cases if it's going to be like toxoplasmosis, right? So it is going to create an hyperpigmented chorioretinal atrophy. Tuberculosis again creates a hyperpigmented chorioretinal atrophy. When it comes to non-pigmented chorioretinal atrophy, when you think about viral conditions like varicella zoster causing an acute retinal necrosis, or herpes simplex 1 and 2 to a certain extent, again it causes non-pigmented chorioretinal atrophy. So these are the ways by which, just on the manifestation alone, we can be able to have a pattern by which we can find a possible etiology. Having said that, there are conditions where you don't see any inflammation inside the eye, whereas the inflammation is subclinical, and there is a predominance of non-chorioretinal atrophy which can happen. So the paraneoplastic ones and to a certain extent azure can manifest in a similar way, which can be picked up on autofluorescence. So on both these conditions, depending on pigmentation, non-pigmentation, and on clinical or subclinical, we will be able to find out a possible etiological agent by looking on categorizing the atrophy.
Retinitis produces less pigmentary changes like acute retinal necrosis when they resolve, or CMB retinitis when they resolve. They don't put pigmentations, but whereas that choroiditis always have some kind of a pigmentations, and RP hypertrophy, as well as the choroidal pigment proliferation.
Thank you, sir. Partho, do the area of atrophy increase over the time, especially during the quiescence phase of a disease?
Sorry, sir, I just missed the.
Yeah, so do the area of atrophy increases, especially during the quiescence phase of the disease?
Yeah, it can, sir. Sir, as just a quick link to the previous question also, I think I'll just answer that also partially while answering this. I think the atrophy depends on not only the clinical phenotype of uveitis, rather I'll classify them what are the factors that determine the atrophic lesions in uveitis. One is the type of uveitis, what is the clinical phenotype, and the etiology, as Dr. Avinash nicely explained that in toxo and tuberculosis there may be this thing. Another is the atrophy or the RP hyperperturbation or the movement of the RP determines on the duration and severity of the inflammation also. For example, we have seen in sympathetic ophthalmia, if it is not treated for a long time or suboptimally treated, then we see a different kind of pigment migrations. And also the treatment response, that how the particular entity is responding to the treatment. And one, we don't know, maybe there are some individual variations also, because same kind of clinical phenotype with same kind of treatment, sometimes we do see subtle, maybe very subtle, but different kind of pigment hyperpigmentation and all. So the atrophy, I don't think there is a particular, maybe the clinical phenotype is the most important factor, but there are other factors as well which will influence the atrophy in uveitis.
For example, the mutes doesn't really leave any footprints. It's almost like, it becomes normal, whereas the other multifocal choroiditis will be producing the pigment proliferations and scarring.
So do the pattern of atrophy vary whether it's the case is treated by a steroid or a biologic or a immunomodulators, that way?
The prompt treatment would be how soon you start the treatment. If you start the treatment soon, that proliferation will be less.
So in other words, irrespective of the agent used, the atrophy would be predominantly determined by the phenotype.
Yeah.
Okay. We do not seem to be having any specific questions for the UVR, so I shall move on to the next talk that's on the retinal vein occlusion, and we'll have Dr. Kim and Dr. Anand. I'm not sure if Dr. Munna is also online for this. So Dr. Kim, I have a question for you. How does the duration and severity of the macular edema influence the likelihood or the extent of neuroretinal atrophy in patients with vein occlusion?
I think Dr. Kim is.
Anand, if you could take this. Yeah.
Yeah. So you said you talked about duration.
Duration and the severity.
Yeah, I think that is quite, again, intuitive. That when you look at a CRVO or any RVO macular edema, it is you look at primarily the severity of the involvement in terms of the volume of the macular edema there, and of course it always helps to know how the duration. And you have soft signs there also to tell you that this is chronic. And then definitely, as I think Chetan also pointed out in his couple of his slides, duration does have a strong bearing. So if that volume of fluid is sitting there for a long time, you can expect the deleterious effect causing those snapping of those molar cells, again taking off from Jay's talk earlier. So the same drill changes which you see, which were talked about first in diabetic macular edema, those kind of changes have also been seen in RVO macular edemas also. So that has a bearing with chronicity for sure. So it's not just chronicity, it's also the extent of severity. As pointed out again by Chetan, you'd also, here is where the periphery and looking at those extent of non-perfusion areas, all that would tell you that, this is a very severe case of, or an ischemic case of CRVO. Obviously, a case of an ischemic CRVO has a poorer outcome. As he has mentioned, more than 3/4 of them tend to present with less than 660 vision. So definitely chronicity and severity have a strong bearing.
So, Dr. Chetan also alluded to the start of the treatment. So he said that especially in a branch retinal occlusion, probably the ideal time to hit the edema is when it's at peak versus early. So what's your take on this vis-a-vis the CRVO?
Yeah, I think, we all started treating, waiting with BRVOs. Our initial dictum was to wait for some time and then allow some time for the edema to resolve by itself. That was how we began, but today, in today's anti-VEGF era, we know that to treat early is always beneficial. It doesn't pay to help keep that macular edema for however long you can. And patients also today, come in, expecting early resolution and hope to see, good outcomes. So I personally, in my practice, I do not, if I see our BRV also with, macular edema, and if I know it's been there for a couple of weeks, I will not hesitate to suggest anti-VEGF therapy almost instantaneous. I wouldn't want that macular edema to fester there for any period of time. I think this issue of apoptosis is a little overstated, and we also know from our practice that BRVOs do respond fairly well to just a few injections vis-a-vis CRVOs, which is a different ballgame. So I think for BRVOs, macular edema, I would not hesitate to treat as quickly and get the patient to as good a vision as he can.
Dr. Chetan, your take on this?
So I would probably slightly digress from what he said, because what happens is very rarely that you actually see a patient come walking to your clinic immediately after an occlusion. Generally, they come when the vision starts dropping, and that usually, clinically when the macular edema becomes clinically significant, so much so that the patient actually starts having a vision problem that it comes. And so when we usually see a patient, it's usually around 3 to 4 weeks after the event. And then that's where you can looking at, as he rightly said, you just look at the vein occlusion. If suppose it's a large major occlusion, you see a lot of hemorrhage and stuff like that, it's not wrong to start the treatment early. But when you see that there's not many hemorrhages, again, it depends on the kind of occlusion. If it's a very severe occlusion with a lot of hemorrhages and a large quadrant getting affected, it's a major occlusion, then obviously the damage is more, and you could expect more atrophy because of the underlying ischemia, which you cannot identify at that time. So that's the role where the OCT plays. Despite all that, you can actually see the superficial capillary plexus damage much earlier than what we would have done on an FFA. We were usually doing FFA before, waiting for the hemorrhages to clear, but now we don't do that anymore. So we go by clinical findings as well as visual acuity and the OCT findings, and that helps us. So I would say that in CRVO, I will not take a chance. I would probably treat it as early as possible. In BRVO, it is a waiting game. You can give it, I would probably give it after 4 weeks, at least, not earlier.
So I'd just like to, qualify and clarify what I mentioned. When I mentioned BRVO with macular edema, I meant BRVO with vision deficit. So if somebody walks in and accidentally is a patient who just walks in for any odd complaint, and I see a little bit of macular edema, incipient BRVO with minimal intraretinal fluid, cystic change, and the patient is 6'6" or barely 6'6" part, and the patient has not noticed any visual deficit, that's a rarity. That's an accidental walk-in. So in such a case, obviously, I would not, and maybe I would even suggest just better control of his systemic parameters. Most of them tend to be either diabetic or hypertensive. So I would do that. But if somebody, when I meant treat early, I mean somebody who is symptomatic, has a significant drop in vision, let's say 6'12" or 6'18", I would not hesitate to treat them. And there also, you can have BRVOs where some of the fluid is actually extrafoveal, even sometimes extramacular, because it's a segmental issue. So in such cases, yes, of course. But if the patient is definitely symptomatic, then I would not hesitate.
So last couple of questions. Chetan, what impact do systemic factors such as hypertension or hyperlipidemia have on the progression of these neuroretinal atrophy? We have been talking a lot about local features at the eye, but the systemic features, do they have a role?
See, the point is that it's actually a localized. It's like a CNS injury. It's unlike even when you have a stroke, you tend to give a lot of anticoagulants, stuff like that. That's because what you have is they have a reperfusion injury, and that creates even more ischemia and damage to the CNS. Unlike in the retina, you really don't have that much of superficial injury. That happens a little later when you start seeing when the edema starts coming down, and then you can have a little bit of reperfusion because the occluded vessel just opens up a little bit because of the VEGF activity. So that really doesn't happen in the eye so much. So we all know that aspirin and everything has been tried before, and it's not going to really work. But the most important point is when you have a vein occlusion, if you have a patient who has not been worked up before for any systemic factors, that's when you have to send him to the physician to look out for these the routine what do you call predisposing factors, especially in a older gentleman or a lady. You will have to look at hypertension and diabetes and other factors. Well, that is more important because we know very sure that branch vein occlusion in one eye can be followed, can we have another vein occlusion in the same eye, or worsening of the same occlusion, or in the other eye itself. So that is where it's important, but we take care of the systemic factors to prevent another recurrence or worsening of the same occluded vessel.
Okay. So the last question for Dr. Anand. The emphasis on both the talks was looking at biomarkers, and obviously it puts a lot of emphasis on newer gadgets, newer tools, toys, if you may say, in the clinic. So what would be your take on what should be an ideal combination of equipment that one should have to pick up such cases when you're practicing vitreoretinal or uveitis?
Yeah, so I think, the emphasis was on two things, with respect to the branch vein occlusions, as well as probably uveitis. A good fundus photograph, and we heard Padma Malik talking excellently about pattern recognition. So for us, for retina specialists as such, pattern recognition, color is pretty important. So I think having good fundus photography at baseline, as well as on the other hand, structural OCT helps a great deal. So I think these two, for a very basic retina practitioner, uveitis practitioner, I think these two are critical. A lot of times people don't forget, a lot of my fellows also forget to take the fundus photographs. That's something I get little, bugged, because sometimes the diagnosis is right there, and you can retrospectively also pick up that. Sometimes, it takes a different course. But I think fundus photography and the structural OCT, and especially a good SD OCT is critical. So you might want to also, especially in uveitis cases where there's a choroidal involvement, perhaps do enhanced depth imaging if you have the spectralis machine with you, and that might help look at sub-RP structures. So having a good fundus photograph, I think that is very good. Yes, there is an emphasis nowadays on newer gadgetry, wide field photography, and those are good to have. But I think good posterior photography as well as good structural SD OCT, that's critical. You may or may not want to have Octa alongside. I think that is an additional tool, but since your question is about basics, I think these are two basic things.
Okay, so thanks all the speakers and the panelists, and now I hand over to Dr. Dhanashree to take forward the next session.
Thank you. Thank you, Girish. Can I request Sarvanan to please put me?
Dhanashree, you're on. You can go ahead.
Okay, but I cannot see him myself actually, so I was wondering. Okay, so good evening, everybody, and so we are now coming to the last session of this very interestingly themed conference that was on atrophy. And the last 2 days we actually had wonderful sessions, and it has been a great learning experience, I must say. We learned about atrophy in inherited retinal disorders. We learned about atrophy in AMD. We learned about the atrophy in myopia, and we also learned about atrophy in vascular diseases and also uveitic diseases. So that brings us to the topic which we are going to cover now. And this topic, I must say that this is something which we all take for granted. So, this is the atrophy, which is a consecutive atrophy which occurs following exudative RD or rheumatogenic RD. and also iatrogenic atrophy, which is created by all of us when we treat these numerous patients of retinal disorders. And we have two stalwart speakers in this session who are going to talk to us about these wonderful topics. The first speaker is Dr. Lingam Gopal, and he needs no introduction. He is a distinguished consultant in Shankar Nethralaya and a researcher par excellence in National University, Singapore. And I will request sir to talk on his topic, which is atrophy after resolution of exudative and rhegmatogenous retinal detachment. So over to Dr. Lingam Gopal.
My friends, at the outset, I'd like to thank Dr. Rajiv Raman for having invited me to participate in this meeting on an interesting concept of atrophy and its effect on the visual function. I have been asked to talk about atrophy in relation to retinal detachment. I would like to restrict my talk to rhegmatogenous retinal detachment. We understand that atrophy is a reduction in the size of cell, organ, or tissue after it has attained its normal mature growth. In this presentation, the concentration would be on that of photoreceptors as well as the other cells in the retina that are secondarily affected. Necrosis, apoptosis, and autophagy are three important mechanisms of cell death, although there are several other mechanisms described which may overlap with these. Necrosis is uncontrolled cell death, usually triggered by infections, toxins, chemicals, or ischemia, results in alkylating DNA damage, and cytoplasm is swollen along with organelles, leading to plasma membrane rupture. This releases antigens, triggering immune and inflammatory reaction. In contrast, apoptosis is a programmed cell death wherein there is no inflammatory response, there is no swelling of the cytoplasm or organelles. The cell in fact shrinks and is ultimately removed by neighboring cells. The caspase proteolytic cascade is important in triggering apoptosis. Autophagy is another important way of regulated cell death, which is important for the cell housekeeping and maintenance. It removes the damaged proteins and organelles, especially in these highly metabolic, non-dividing cells. Macroautophagy refers to removal of large substrates, while microautophagy refers to removal of small protein molecules which are malformed or misfolded, removal by lysosome membrane invaginations. The balance is important because both increased and decreased autophagy could be detrimental to the cell health. A word about necrotosis, since it is a word derived from necrosis and apoptosis, and also shares some of the mechanisms of the two. We refer to necrosis as a kind of cell death that releases a lot of antigens and triggers inflammation, and typically it is not caspase related, while apoptosis is caspase related and causes very little inflammation. Necrotosis, on the other hand, is also a programmed cell death similar to apoptosis, but it is caspase independent and does trigger inflammatory reaction. What are the changes that occur after retinal detachment? The immediate changes are phosphorylation of fibroblast growth factor, which is expressed by the retinal pigment epithelium. There are also increased expression by the Mueller cells of regulated kinase and activator protein transcription factor. These lead to several changes in the cells. The retinal pigment epithelial cells are the most important. They undergo epithelial mesenchymal transition. The apical surface is altered since it is no longer in contact with the photoreceptors. There is migration of loose RP cells into subretinal space in which proliferate. And there is also effect on the photoreceptor outer segment renewal because it's not in contact with the same. The villi that surround the photoreceptor outer segments are lost, leading to RP cells becoming rounded. The cytoplasm protrudes into subretinal space and the nucleus is displaced towards the apex of the cell. However, these changes are restricted to the area of detached retina, and the proliferative response of RP cells appears to be self-limited. The second important change that takes place is the degeneration of photoreceptors, which is what we are concerned about in this particular presentation. The photoreceptors degenerate by way of apoptosis, although some believe that there is also necrotosis involved. Within 24 hours, one finds apoptotic cells, and the cells number peak by 2 days and then become lower. The apoptotic activity does persist at low levels even as long as the retinal detachment persists. In general, rods degenerate faster than cones. Also seen are the changes in the synaptic terminals of rods and cones, which is the spherules and pedicels that are present in the outer plexiform layer. These tend to retract and now they are located in the outer nuclear layer. Apoptosis, as has been alluded to, is mediated by caspases 3, 7, and 9. However, receptor interacting protein kinase RIP can promote necrosis even in photoreceptors. This is what has been referred to as necrotosis, because in an experiment which I will share with you later, we found that just blocking the caspase does not prevent the apoptosis. Outer segments become vacuolated and shorter in 1 to 3 days' time, ultimately becoming empty sacs, but the cilium is retained. Debris from the outer segment are shed into subretinal space where they are phagocytosed. However, the outer segment specific proteins continue to form, and once they are formed, they are not being processed properly by the retinal pigment epithelial cells, and hence they accumulate at odd locations within the cell. The opsin accumulates in the plasma membrane, while the peripheral RDS, which is related to the rim protein, appears in the cytoplasmic vesicles. In general, cone outer segments are more susceptible, and hence the cone opsin is rapidly downregulated. The inner segments of photoreceptors also undergo change in terms of swelling, disruption of mitochondria in the ellipsoid zone, and similarly disruption of Golgi bodies and endoplasmic reticulum in the myoid zone. The connecting cilium is retained, and this is rather important for the regeneration of retina to occur once the retina is reattached. The nuclei of rods and cones also undergo vacuolization and degeneration of mitochondria and disorganization of the microtubules and actin filaments. In this picture, we see that 3 days after inducing retinal detachment, the outer nuclear layer thickness is grossly reduced. The bipolar and horizontal cell dendrites also are affected because the rod spherules and cone pedicels are retract now into the outer nuclear layer from the outer plexiform layer, where they're actually synapsing with the dendrites of the bipolar cells and horizontal cells. Hence, these dendrites now grow into the outer nuclear layer and sometimes all the way into subretinal space as well. Mueller cells also migrate from the outer nuclear layer, migrate to outer nuclear layer and outer plexiform layer, and their processes can extend into subretinal space, causing retinal gliosis. The subretinal space is normally free of cells, but within 24 hours of retinal detachment, it has polymorphonuclear leukocytes, monocytes, and macrophages emanating from the chorea capillaries and the retinal vasculature. There are free RPE cells and outer segment fragments, as has been explained already. On reattachment of retina, cell-to-cell contact between RPE cells and photoreceptors takes place. The apical surface is redifferentiated to produce villi that ensheath the outer segments, and there is synthesis of interphotoreceptor matrix, which is important for the transmission of the biochemical factors across the cells. But the establishment of a good functional relationship between RPE and photoreceptors that leads to a good balance between addition of discs and the disc shedding and removal by the RPE takes several months after reattaching the retina. So, can one prevent degeneration of the retina after retinotosis retinal detachment? Obviously, scientists are working with several target molecules. First, they tried was to block caspases because caspases are important for the occurrence of apoptosis. However, it was found that when you block the caspases, although apoptosis is reduced, necrosis tends to take over because of upregulation of RIP3. And hence, blocking of both RIP3 and caspases is when the damage to the photoreceptors can be reduced. Autophagy is supposed to be important in the damage to the photoreceptors in the sense that if one were to enhance or prolong autophagy, it seems to increase the survival of the photoreceptors following retinal detachment. And this inhibition of by calpain or inhibition of calpain 1 and TNF alpha produces prolongation of the autophagy and thus indirectly reduces the photoreceptor loss. Microglia are said to be very important in the overall causation of damage of the photoreceptors after retinal detachment. It is seen that if you block the pro-apoptotic molecule BAX or reduce the deficiency of TREM2, we understand that photoreceptor cell death can be prevented to some extent. Similarly, inhibition of TRPV4 ion channel can protect the photoreceptor damage, while myosin 1F deficiency can protect photoreceptor damage because it's actually upregulated. This is an error in the word here. It's upregulated after detachment, and hence downregulating it can protect photoreceptors. Antibodies against MCP1 can also protect photoreceptors after detachment. An interesting experiment was done called photoreceptor metabolic reprogramming. We understand that photoreceptors have a high demand of energy. Although it's an aerobic environment, the photoreceptors can also use glycolysis instead of the oxygen environment to feed the need for energy. PKM2, which is pyruvate kinase muscle enzyme isozyme 2, is a key regulator of aerobic glycolysis. In PKM2 knockout mice, chronic degeneration of outer retina was observed, but incidentally they also found it gave survival advantage for the photoreceptors after retinal detachment. How far this can be translated into an experimental model or a target that could be inhibited is not clear. There are various other molecules which have been either enhanced or inhibited to try and protect the photoreceptors. IL-6 injection or increase in the heat shock protein 70 could potentially protect the photoreceptors. Resveratrol is a drug that reduces the caspase pathway activation and can protect the photoreceptors. Insulin itself has been found to inhibit inflammation-induced cone death in detachment of retina. And potentially even metformin can work because it's an insulin sensitizer. Various other factors that have been tried are BDNF and CNTF. In fact, combination of the two was found to be better than any other of them. Edaravone is a free radical scavenger. Minocycline is an antibiotic. And high oxygen concentration in the inspired air is also supposed to be protective of the photoreceptors. So these are various factors that are being attempted to try and save the photoreceptors from damage following a retinal detachment. However, we still have a long way to go before there's a molecule available that could be injected during retinal reattachment surgery and help recover a good macular function as well as peripheral field of vision. Thank you very much for your kind attention.
Thank you, sir. That was a very exhaustive talk. And thank you for giving us the basic nomenclature and the basic pathology behind atrophy and retinal detachment. And as sir's characteristic style, he likes to go to the very bottom of the problem. And you can see how exhaustively he has gone to the bottom of this question. And now you know why he's such a good researcher. So, but without wasting further time, I would like to invite the next speaker in this session, Dr. Mahesh Shanmugam. He is the head of the Department of Vitreoretinal Diseases of Shankara Eye Hospital, Bangalore. And I invite sir to talk about iatrogenic induced retinal and choroidal atrophy in BR surgeries. Over to Dr. Mahesh Shanmugam, please.
Good evening, everyone. It's indeed a pleasure to meet you all virtually this evening. And I thank Rajiv, Chetan, and the Sankarnatana team for this opportunity to meet you all virtually. It is indeed interesting that they've come up with atrophy as a topic for their conference, and they made sure that I work for my bread by giving me a topic on iatrogenic induced retinal and coronal atrophy in VR surgeries. I really had to squeeze my brain to come up with the presentation, and I hope that you find it useful. I have broadly classified atrophy as bad atrophy and good atrophy. Bad atrophy is something which is not desirable and has resulted in vision loss, and it was inadvertent. And good atrophy is something which is intentionally created to make sure the patient maintains the vision. Something like surgical photocoagulation cryotherapy, where we do create atrophy, but at the same time, it's for the larger good. Let us start by looking at examples of bad atrophy. This is a patient who underwent vitrectomy for backlog hole, and this is a slide I have borrowed from an article by Jain et al. In Survey of Ophthalmology in 2012. In the postoperative period, they found these areas of pigmentation beneath the retina. Unfortunately, it does not involve the fovea. And on fundus fluorescein angiogram, we can see areas of hypofluorescence. So what is this an example of? This is an example of phototoxicity, and phototoxicity has been found to be more common in backlog hole and epiretinal membrane surgeries. And the phototoxicity is dependent on the duration of exposure, wavelength of light, angle at which we illuminate the retina, and the phototoxicity may be augmented with some dyes, ICG in particular. The closer the light pipe is to the retina, more is the chance of the phototoxicity. And backlog hole DRM surgeries, we tend to keep the light pipe close to the retina for a little longer period of time, and we are concentrating on peeling the ERM and epiretinal membrane. In the process, may inadvertently cause phototoxicity. Other factors such as halothane and some drugs, if the patient is on, can increase the risk of phototoxicity following VR surgery. A recent publication hypothesized that paclitaxel is a drug that can increase the chance of retinal phototoxicity. And here is an image from the article which shows that the patient underwent backlog hole surgery, following which extensive areas of RP and retinal atrophy can be seen involved in the posterior pole, which is seen distinctly on the fundus autofluorescence. On the OCT, you can see that though the backlog hole is closed, there is outer retinal atrophy as well as RP atrophy. It's not often that we come across patients with phototoxicity, but then we can take some small steps to decrease the risk of phototoxicity when performing vitreoretinal surgery. We start with minimum illumination, just about adequate to see the fundus clearly and accomplish the surgical goals. You can keep the light pipe away from the retina, particularly when performing macula surgeries. And even if you were to take it closer, we can limit the duration of the light exposure to the retina and pull it back consciously and then go back and perform the surgery. Digital viewing systems digitally enhance the amount of illumination, thereby decreasing the need for light, and they decrease the light need quite significantly, that the risk of phototoxicity is quite less. Of course, not everyone can afford the expensive digital viewing systems. We can also use safe wavelengths. Something like a blue light can be toxic, and avoiding it. Now we have these light systems where we can select the type of illumination which is required, the wavelength which is required, and using these safe wavelengths can also decrease the risk of phototoxicity. When we are using dyes, if there's a macula hole, it's better to inject the dye in a fluid-filled cavity so that it doesn't go under the retina through the hole and percolate and cause RP alteration. And it's always also better to avoid subretinal migration in retinal detachment cases, wherein the dye may be difficult to remove after injecting into the subretinal space and can cause RP toxicity. Here we see patient with an appearance similar to phototoxicity, areas of RP alteration, but then here it was due to mechanical trauma. These were areas of instrument touch when our fellows were operating, resulting in areas of choroidal atrophy. Fundus autofluorescent imaging shows these areas of RP alteration much better in mechanical trauma as well as in phototoxicity. Here are the OCT images passing through these areas of instrument touch, which show disruption and disorganization of the retinal layers. Here we see effect of a much deeper trauma, wherein the choroid and the RP is also involved, and we see a fibril scar growing through this area of instrument touch. So how do we decrease the risk of instrument touch amidst fellows? We usually have them evaluated for their stereopsis when they begin their fellowship, and surprisingly we find that many of them do not have adequate stereopsis, and make sure that they undergo adequate necessary exercises to improve their stereopsis. And focusing of the biome is another reason why they may not be seeing appropriately and the depth perception may be impact, and we have to teach them to focus the biome appropriately. Another cause for RP and photoreceptor atrophy post-vitreoretinal surgery is a subfoveal retained perfluorocarbon liquid. If it is beneath the fovea, it can definitely cause vision loss as well as permanent vision loss because of photoretinal atrophy and RP loss. So with subfoveal, we need to try displacing it or removing it, and try displacing it by doing pneumatic displacement. But if the retina is detached to some extent, if there is some fluid, then the pneumatic displacement is easier. Otherwise, it may not budge, in which case a surgical removal would have to be done. If the subretinal PFC bubble is not in the fovea and elsewhere, we can watch and barrage it with laser so that it doesn't move subsequently. Here's an example of removal of the subfoveal subpapillomacular bundle PFCL, fairly a large bubble. We are using a 42 gauge cannula to see if we are able to aspirate it, but we are partly successful in that, like only part of the bubble can be aspirated, but then the small bubble could be aspirated completely. So the larger bubble ultimately had to be removed using a flute needle. And there are techniques displayed wherein people have created a macular hole and remove it and then do an ILM peeling and close the hole. So here we did peel the ILM, but then there was no macular hole. There was a retinotomy nasal side of the fovea through which we managed to remove the PFC. Here is the early postoperative image of a patient who underwent an uneventful vitrectomy for a ectodermal retinal detachment. We see some amount of vascular sclerosis and extensive retinal hemorrhages. There is nothing intraoperatively to explain these hemorrhages, and sometimes we have seen these changes after silicone oil injection, and we tend to think that it's because of silicone oil toxicity. In the follow-up period, though the hemorrhages have resolved, we do see that there is some amount of retinal atrophy and thinning of inner layers of the retina. Some of these patients do have poor visual recovery, as in this example, where we do see extensive RP atrophy and retinal layer disorganization after silicone oil injection. The reason for inflammation and atrophy of the retina could be due to silicone oil toxicity, chemical toxicity due to a particular brand of oil, and case reports of such do exist in the literature. It's not as though like every patient who undergoes silicone oil instillation from a particular batch of silicone oil will develop these changes, and it's as yet unclear as to why some patients seem to be prone to developing this silicone oil toxicity. Similarly, there have been reports of unexplained vision loss post-silicone oil removal, and some of the causes hypothesized are electrolyte shift within the vitreous cavity, which increase the excitotoxicity within the retina, intraoperative phototoxicity, and one interesting phenomena is environmental light phototoxicity during silicone oil tampering as the result of poor short wavelength filtering by the silicone oil and direct retinal toxicity. Though we may not be able to predict which patients will lose vision after silicone oil removal, using silicone oil from well-established manufacturers may decrease the risk of chemical toxicity due to a particular brand of oil. Here's another extreme example of silicone oil-induced retinal atrophy. This patient had undergone vitrectomy for myopic traction maculopathy, and the primary surgeon had instilled silicone oil. But silicone oil, you can see, is accumulated within the layers of the retina and in the subretinal space. It was challenging as the silicone oil, which was emulsified, was incarcerated in the layers of the sciatic retina as well as the subretinal space. And during the revitrectomy, we identified that the posterior hyaloid was still intact, which was identified by the triamcinolone. We removed the posterior hyaloid and very carefully removed the internal limiting membrane and used a perfluorocarbon bubble to milk out the subretinal emulsified silicone oil. We had to repeat this multiple cycles to see if we are able to remove as much of the emulsified silicone oil stuck up in the right side of the subretinal space. And this was through a pre-existing break. This is the OCT image. In the post-operative period, we can see that we have managed to reattach the retina and collapse the splices. Because the long-standing intraretinal emulsified oil, there is some amount of retinal atrophy, and the patient's vision did improve after this surgery. The other major reason for loss of vision and retinal atrophy and RP atrophy is the drug toxicity. So post-endophthalmitis treatment, aminoglycoside toxicity used to be a cause for loss of vision. As you can see here, there is avascularity of the macula, resulting in loss of vision and blunting of the retinal and choroidal muscles. The incidence of aminoglycoside toxicity has come down because we are avoiding gentamicin, tobramycin, and amikacin as an intravitreal drug. And what is interesting is subconjunctival use has also been documented to cause this. So cataract surgeons injecting any of these into subconjunctival space may also inadvertently cause glycoside toxicity, and this is preferably avoided. I'm sure most of the cataract surgeons do not use these drugs in the subconjunctival space anymore. Of late, we have been performing vitrectomy in certain patients with retinoblastoma complicated by vitreous hemorrhage and retinal detachment. And most often, these are one-eyed children, and it becomes imperative to save the only remaining eye of the child. To decrease the risk of an extraocular spread and also to take care of any possible active tumor inside the eye, we do use melphalan in the infusion. And melphalan has been known to cause such extensive RP, depigmentation, and pigmentation. It looks very scary. And to decrease the risk of this happening, we can use the topotecan as an alternative. And it's always imperative to check the dose of the intravitreal drug before administration because slight change in the dose of melphalan can cause the extensive RP alteration. And children who have had prior IVC, that is intravenous chemotherapy or intra-arterial chemotherapy and intravitreal injections of melphalan seem to increase the risk. We need to keep this in mind before injecting melphalan in these children to decrease the risk of RP alteration. Here's an example of a patient who underwent vitrectomy for peripapillary macular TID. It's a flat proliferation. And post-operatively, you can see that the retina is attached, but we can see progressive disc pallor, and also the vision has dropped. This may be because of increase in the intraocular pressure to decrease the risk, decrease intraocular bleeding, or maybe because of silicon oil toxicity. It's difficult to explain, but sometimes after reattachment of the retina in a TRD, there are pigmentary alterations involving the macula, which can limit the vision improvement. And actually, sometimes these people have lesser vision than we started with an optic atrophy. These are difficult to explain to the patient post operative period. Let's look at some of the examples of good atrophy where we intentionally create this atrophy. Here we see an example of a choroidectomy following post-traumatic retinal attachment. Patient had had multiple vitreous surgeries and kept recurring because of fibrovascular proliferation from the site of globe perforation. So this was the preoperative appearance. We can't see the disc and the retina is contracted and pulled towards this scar. So excising the retina and the RPE and the choroid around the site of globe perforation seems to decrease the risk. In posterior globe perforation with fibrogland proliferation, we do perform a rectectomy around the fibrogland scar. Then attempt to decrease the risk of the fibrous tissue growing across the retina, removing the retinal scaffold. But doesn't seem to work in all the cases, and the fibrous tissue seems to grow across the choroid as well and drag the peripheral retina into it, thereby causing recurrence of the retinal detachment. So performing a choroidectomy and removing this scaffold around the fibrous tissue and isolating the fibrous tissue has been advocated as one of the methods by which we can decrease the risk of retinal detachment. So that's what we did in this patient. You can see bare sclera around this area of the fibrogland scar, but of course it has resulted in a large retinectomy as well as choroidectomy, but this did decrease the risk of a retinal detachment in this patient. Moving on to other examples of good choroidal atrophy, we do intentionally create choroidal atrophy in tumors to destroy them and thereby retain the vision and restore the vision. Here we can see the appearance post-operatively where the macula has gone back to its place and the patient's vision has improved despite extensive choroidal atrophy. We do intentionally create choroidal atrophy even though if it involves a papillomacular bundle or close to the macula in retinoblastoma to destroy the tumor and save the eye and some vision in these children. Post-brachytherapy for melanoma, 50% of the patients tend to lose vision because of radiation retinopathy, and we treat them with intravitreal anti-VEGF agents. But here is one patient where despite multiple intravitreal anti-VEGF agents and steroids continue to have toxic tumor syndrome and recurrence of macular edema, wherein we decided to remove the tumor, that is the dead tumor, to decrease the risk of the toxic tumor syndrome. So here we can see the retinectomy is performed and the retina is folded back and the tumor is removed. Thereby it doesn't release these VEGF or toxic tumor factors which increase the risk of the radiation retinopathy. So this is a post-operative appearance is an intentionally created choroidal atrophy. Here's one such patient who has had resection of the tumor and a follow-up of more than 8 years, wherein there is no recurrence of the macular edema and continues to maintain the existing vision. So choroidal atrophy post-vitreoretinal surgery can be because of phototoxicity, chemical or mechanical factors causing atrophy. We did look at the techniques to decrease the risk of choroidal atrophy during vitreoretinal surgery, though recovery may be limited in certain cases, particularly when it is drug-induced toxicity. We do create intentional atrophy as a sequel to treating tumors, but in the larger interest of saving the eye and some vision, we do create this atrophy. Thank you very much for your kind attention.
Thank you, Dr. MPS. That was really an exhaustive talk, and you covered almost all the causes of iatrogenic atrophy under the sun, a whole gamut of causes you have listed. So I would like to invite the panelists now for this session, and I take the pleasure in inviting Dr. Shobhit Chawla, who's a senior vitreoretinal consultant in Prakash Netra Kendra, Lucknow. Dr. Rajiv Reddy, who is a vice chair in LPPI Hyderabad, and Dr. Pramod Bhende, who is the head of the department, vitreoretinal department in Shankar Netralaya, Chennai. So I welcome you all. I think maybe, sir, if you log out and log in again, that might help.
again going off contact, coming in contact, going off contact. It takes some time for the actual interface to be functional. In fact, it's said it takes several months for the functional relationship to be re-established. So I don't think shifting fluid necessarily protects the retina from degeneration. The fact that there is some ongoing process which is keeping the retina detached does cause photoreceptor loss still. But as exfoliative body, as I said, is a very heterogeneous group. So it's very difficult to compare one case with another case because of other reasons why there could be a damage of the photoreceptors.
So while it has been a very interesting discussion, and I think we can go on and on, but I think we have to wrap it up, and I got a message here that to wrap it up. So thank you very much, the speakers and the panelists and the audience.